Good afternoon. Good afternoon. Let's come to order. Welcome back. I understand you've already all have been blessed, so I will just proceed with the introduction here. It's my pleasure to introduce an old friend and colleague, Jeff Bishop. Jeff is now, and I just checked on the pronunciation because I've never been quite sure, is the director and has been since 2010 of the very exciting Albert Ganegi Center for Healthcare Ethics at St. Louis University, pumping out, in my opinion, some of the best educated and best prepared PhDs in bioethics in this country. And on that score, I just want to mention Jeff is one of a number of people at this conference who are part of, I think, a new wave in bioethics. In my introduction of Loris, I mentioned his work at the Bioethics Center at the University of Iowa. Ryan Nash in his very exciting new Bioethics Center at Ohio State. Anna Iltis, who's here, her very exciting Bioethics Center at Wake Forest. Kevin Donovan, who is picking up the reins from Ed Pellegrino at the Bioethics Center in Georgetown. And I think Carter should be proud, I certainly am, that all of these people who are doing exciting new work in bioethics and institutional work, creating new institutions, were nurtured in some way by this conference. And on this 30th anniversary, I think that's one more thing we can celebrate. Not that we take credit for all their good work, but it's very nice. Jeff is another PhD, MD, PhD from his MD from University of Texas Medical School, his PhD in philosophy from the University of Dallas. He's held teaching positions at a number of other places and visiting places, including Vanderbilt. His scholarly interests, and I'll read this from his own descriptions, include the historical, political, and philosophical conditions that underpin contemporary medical and scientific practices and theories, which is to say Jeff is interested and knowledgeable about almost everything. And one of the most, if you have time to have one more dinner with someone, I suggest you pursue Jeff. The conversation will be fun. And we are also very proud that his exciting book, I tried to sell some books for Loris, and let me try to sell some for Jeff as well. The title is The Anticipatory Corpse, Medicine, Power, and the Care of the Dying, was published in the Center for Ethics and Cultures series at the Notre Dame Press. And it is, again, in Jeff's language, and this seems to me accurate, a philosophical history of the care of the dying from ICU care to palliative care. It's a very exciting book, and Jeff is one of the most interesting young scholars in bioethics and is shaping the field in all sorts of interesting ways. The lecture today is entitled Physicians' Orders for Life-Sustaining Treatment and the Problems of a Proceduralist Bioethics. Jeff, take it away.
Thanks, David.
Yep.
So I have this, what I consider to be a real problem of you've been fed spiritually by the blessing of the Holy Father, and you've had a nice Italian lunch, so somehow I have to keep you awake. I wanted to just put a plug in for a little symposium that I've put together at St. Louis University's Madrid campus. And the Center for Ethics and Culture is a co-sponsor, also with the Center for Bioethics and Human Dignity. It's called Bare Life and the Moral Life. I've gathered about 12 scholars together to think about the relationships of bare life to the moral life and how all of that works. And they're all coming to give papers, and we'll have respondents. And it's in Madrid. Also, I'll be in Madrid teaching a course called Bioethics and Human Nature through Film, where we'll do some comparison of Spanish films as to American films, trying to get at what is their concepts of human nature that animate what they think of as legitimate. So if you're interested, if you want to come to Madrid and hang out and have a little sangria, I'll be happy to entertain you. All right. POLST. I just want to go through what I'm going to do today. POLST, we got to figure out what POLST is. So I'm going to go through it a bit. So I'm going to give you a little bit of the definitions. What are its intentions? What it claims to be able to do for us. I'll go through some of the promises and peril of POLST, and then I'm going to kind of begin to do a bit of a critique of it, a plethora of procedures. Or can a proceduralist ethic save, or can a procedure save a proceduralist ethic? And then I'm going to talk about the confluence of forces that work together in POST, and then I'm going to describe how I think these procedures become unmoored from anything of substance. So here it is, the POST form. We've got the CPR, the CPR, or cardiopulmonary resuscitation aspects of it. We've got then other medical interventions that are listed, and then the artificial nutrition and hydration portion of the form. And it's very easy to use because we can just tick some boxes and know exactly the right thing to do morally, or so the story goes. And then we have the information and signature portions of the form where you can tick whether or not you have an advanced directive, who is named as the healthcare agent on the form. This is an example of California's form. Then it's got the signature of the physician because this is a physician's order or a clinician's order. And then the patient, it depends on what state you're in. This patient may or may not be required to sign the form or encouraged to sign the form, or if not the patient, then the patient's proxy decision maker. So, POLST stands for Physician's Orders for Life-Sustaining Treatment. It goes by many other names in many other states. It can be POLST or MOLST, which is Medical Orders for Life-Sustaining Treatment, Clinician Orders for Life-Sustaining Treatment, Medical Orders for Scope of Treatment, or Physician Orders for Scope of Treatment. I forget what TPOP is, so we'll just skip that one. POLST, why was it created? And this is their stated wishes. That patients' wishes at the end of their lives will be known, communicated, and honored across all healthcare settings. It's somewhat related to an advanced directive, as I showed you in that form. You show some connection to it. An advanced directive is a legal document, however, that directs physicians on end-of-life measures in the event of a terminal condition. And most of the time, advanced directives begin with something to the effect of, in the event that I have a terminal condition, I want to direct my physicians to do the following things. Advanced directives are limited, according to the POLST proponents, because it may not be executed by a physician. There's a disconnect between the legal side and the clinical side of the form for advanced directives. So the POLST tries to bring those two back together. Even if executed, the document may not be available, and it's not always included in the medical chart. And so they want to have something that will, you want a medical document, not just a legal document, but a medical document that can be put into the chart. Of course, you could put the advanced directive in the chart if you wanted to. So it's kind of like the DNR in that it is a physician's order. A do not resuscitate order is a physician's order. It's entered into the chart, into the order section of the chart usually, or on a form that acts as an order. And it's unlike the DNR in that it has other things listed like whether or not you want antibiotics or whether or not you want artificial nutrition and hydration. The story goes that it's portable and travels with the patient's medical record. I'm sure it's portable. I'm sure all of you brought your medical records here today, and you're carrying them along, and it's portable right there with them. Supposedly, it's in precise medical language. I don't know. Those tick boxes look pretty empty to me, so I'm not sure it's in precise medical language, but they claim it is. And it's signed by a doctor or another health professional, so there's supposedly greater adherence to the orders. So who can sign it? Physicians, nurse practitioners, and physician's assistants can sign it in some states. Nurses, social workers, or advanced care planners, they're sometimes called facilitators, they can also sign it in some states, not in all states. Does the patient have to sign? Well, in the majority of states, it is required, but not necessarily in all states. And can surrogates sign? Yes, they can in many states as well. So which document prevails, POLST or the advanced directive? Well, it depends on the state. In some states, one or the other is designated to be the one that trumps the other. And in some states, it's whichever one is the most recently executed of the documents. But no state requires a patient to complete a POLST, but some states require the physicians to at least offer the POLST form. Okay? So the story goes that we have to have access to this document. Oregon and other states have an electronic registry that can be accessed easily in an emergency situation. So Oregon mandates submission of the POLST to the electronic registry unless the patient opts out. So it's kind of an you opt in if you just sign the POLST. You have to expressly say, no, I don't want it to go into the registry. And the idea is that when the emergency medical technicians arrive at your home, they have that form and they know not to start anything that's overly aggressive. The goals of POST are ambitious, and they hope to cover all sorts of issues for patients, whether those be acute or chronic illnesses, whether the patient is elderly or just frail, whether the patient is with or without capacity to make medical decisions. And POLST, this is their rationale for it, ensures autonomy, standardizes documentation, optimizes communication, minimizes unwanted intervention, simplifies decision-making, maybe, consistency across care environments, and saves money, according to its proponents. So, I'm going to kind of go through some of the problems with POLST now. So we've heard some of the promises. So we're going to go through some of the problems or some of the perils of the POLST paradigm. It's kind of interesting. It's designed for terminally ill patients, but does not meet Medicare's and Medicaid's definition for terminal, which is 6 months. It's a 12-month document. So there's a disconnect between what counts as terminal in order to receive the hospice benefit and what counts as terminal according to POLST. And it doesn't necessarily distinguish between ordinary care and extraordinary care. And it probably doesn't enable a discussion of that either. I would hope that certain practitioners who are engaged in helping the patient complete one of these forms would indeed be able to help the patient think through some of those issues. For some Catholic organizations, the tube feeds are considered to be ordinary care, okay? And POLST may legislate something against these Catholic hospitals to endorse. So this is a potential problem or a potential peril of the POLST document. It also leads to problems in clinical decision-making in that you have check boxes versus clinical reasoning. Decisions can be remote from the execution of the document. So you might fill it out 6 months, 8 months earlier, and yet it's an order. It's a physician's order. And most of the time, a physician's order is kind of dependent upon the context of what's going on immediately in the surroundings with the patient, right? What's the immediate problem? And, I mean, think about standing orders. We don't necessarily like we like them in certain circumstances as doctors, but in all circumstances, I'm not sure. Some people say that it's problematic because it doesn't require a patient's signature, but then there are a lot of orders that we execute as doctors that don't require a patient's signature. It forces, this I think is an interesting problem. It forces one setting. Okay, so if you're kind of thinking about clinical decision-making as something that's judging what's going on in the moment of taking care of a patient, it forces one setting, say the nursing home, to follow another setting's, the hospital's decision, okay? And so it's kind of a one-size-fits-all, and it kind of overreaches what most of the time we do when we're making clinical decisions. And some people have argued that it has charged language, aggressive versus limited care. Do you want aggressive care or do you want limited care? Versus saying, do you want full care or limited care, right? So the language itself might be charged. Some people have argued that it will undermine the doctor-patient relationship. That the facilitator scripts, and the facilitators are those care planners that I mentioned earlier, the facilitator's scripts might have some biases introduced. I'm reminded of, I'll think of her name in a moment. She's a jurisprudence scholar who wrote a paper on the 1997 decision about how once you have entered physician-assisted suicide into the doctor's black box or the black kit, you open that kit, you get that out, it changes everything. It's not just one tool in amongst all other tools, but it changes the whole frame. And I think that's exactly right. And so the facilitator scripts, if they put this on a continuum of care, it radically reframes the way we think about life and death, okay? So there's also evidence that hospital facilitators may have a conflict of interest in this, right? Get them out of the hospital, they cost less there, etc. But that's, again, always true. Evidence that POLST may not reflect patient wishes. Well, that's always true of DNR orders and advanced directives as well. So I'm not sure that's as big of a problem. There have been some stories, and people have been sued on forging these documents, and so that does happen. But that happens with advanced directives as well. People do kind of. Families will hide them or sign them for a family member just as easily. So that has happened with other forms as well. One of the other problems is it's kind of an ever-expanding circle, right? So if you have something like ALS, which you can live for years with lots of good care, as seen by somebody like Stephen Hawking, right? Some people would say, oh, well, they need to have a POLST, okay? They probably ought to be directing their doctors, because if you get a pneumonia and have ALS, well, you may not want to be intubated, but then again, you might want to be intubated. And so this would be a nice thing for you to complete. So it's kind of this ever-expanding circle. And then you've got somebody who's maybe 85 and extremely healthy. I've seen some very healthy 85-year-olds who you might be encouraged to fill one of these out. Does that help to encourage people to think a little bit more closely towards dying in a way that's problematic? In other words, if death is a potential option, then, well, does it reframe everything? It also is encouraged for anybody who's frail, as I mentioned, ALS, also for those who have chronic non-terminal diseases, okay? People who might have a problem that could lead to their death, and they might need to go ahead and complete one of these, okay? And it may not, some people have argued, it may not respect the consciences of the dissenters, particularly the physician and nurse dissenters who might be encouraged or kind of forced to complete these forms. Now, the Catholic Medical Association recommends an alternative to POLST, and they call it preparation for the in-the-moment need of medical decision-making. Doesn't fit like POLST, a PNND-MD, or whatever it is. Doesn't quite work. But I wonder if any sort of procedure is already kind of selling the farm. In other words, we've got procedures and we start to poke holes in these procedures, which is where a lot of the critiques are. People are worried that somebody's going to abuse it, right? Or it's not strong enough. It's not a physician's order. It might undermine the doctor-patient relationship. So there are things like that. But I think those are primarily procedural problems. And so all you have to do is come up with a better procedure. But what I'm going to argue in just a moment is that all procedures eventually become kind of unmoored from other more substantial positions. So we might be trading one set of procedures for another set of procedures, or creating procedures to solve other procedures, right? It's kind of, this happens all the time in hospitals. You find a problem, we need another policy. Well, let's have a policy for the policies. And then you got to have, we have to have policies for the creation of policies. So you're on the committee to create policies and procedures. So it just kind of goes on, and we get a plethora of policies and procedures. Whoops. All right. Terman, whose article was listed in our readings for today, he suggests that the forms are too vague and suggests that we need more detailed forms. So we've got to have more procedures to solve the problems of the procedures, right? And so he starts to offer very explicit sorts of statements that we can tick boxes on. He still keeps the tick box, but he adds a little granularity to it. So if I reach an advanced stage of dementia, as detailed in my living will, he always wants to make sure that those two documents are going hand to hand. That's a good thing. That's a good thing to make sure those two documents are married up together. Then I do not want to receive tube feeding even though I'm Catholic, right? Or you might say, I want tube feeding, even if I'm not a Catholic, right? So it's sort of... he wants to give some granularity to it to make it more clinically rich, but all he's doing is kind of expanding the procedure. It's still got a tick box, as I'll show you in just a moment. Here's another one. This is another statement he puts in there. If the patient has become dependent on help provided by another person's hand to put food and fluid in his or her mouth due to severe cognitive impairment, not due to physical impairment or handicap, check one of the boxes below. A, do not provide this help, but always offer food and fluid by placing them in front of the patient. Provide this help for a limited time of trial, 8 days, weeks, months, when I will reevaluate the patient and possibly revise my order, or C, continue this help for as long as it's medically feasible, right? And I can imagine multiple permutations of those kinds of decisions. You can't think of everything, right? Here's another one he says that there should be a statement on the POLST form that says the following, right? It should include the following. The physician should consider the following. You incur 3 legal risks if you do write orders that conflict with my living will and its expression of my own wishes are clear and available. The first is criminal, providing treatment without consent, et cetera, right? He wants to make sure that docs really know the gravity of, docs probably need the sword of Damocles hanging over their head. I agree with that. But I'm not sure that a form is going to fix that problem. Where I see the main problem is that I see the confluence of several forces at work. Okay, this is a different sort of problem than just procedural. The POLST paradigm began in Oregon around the time of the first attempt to enact the Oregon Death with Dignity Act. Okay, they both began at the same time, right? There's a lot of activity in the early 90s around this. Okay. Now, that alone doesn't mean much, okay? So let's go a little deeper. The National POLST Paradigm Task Force got together. They were funded by the following foundations. They set out to make the POLST paradigm a priority and to standardize as much as possible a national POLST program, okay? They were funded by the Greenwald Foundation, the Nathan Cummings Foundation, the Open Society Institute, and the Robert Wood Johnson Foundation. And each of these funders has been supportive of Oregon's Death with Dignity Act or other organizations supportive of physician-assisted suicide and euthanasia. They want good dying, I guess. Now I'm gonna show you I'm gonna pull something from my book that I did just to kind of show you what I'm concerned about. The Oregon Death with Dignity Act has the following set of statutory procedures that have to be followed. The first is the patient has to write the physician requesting physician-assisted suicide or euthanasia. Actually, it's physician-assisted suicide in that case. To ensure the patient, and this is now a direct quote from the statute, to ensure that the patient is making an informed decision, inform the patient of A, his or her medical diagnosis, B, his or her prognosis, C, the potential risks associated with taking the medication to be described, right? You have to tell them that if it fails, you may vomit and you may aspirate and you may, it may be a potentially very dark death, okay? They have to say all these things. And E, the feasible alternatives, including but not limited to comfort care, hospice care, and pain control. Notice how hospice and physician-assisted suicide are kind of running right alongside each other right there, okay? It goes on to say, if the physician thinks the patient has some psychiatric problems or might have a depression, right, the consulting physician can refer the patient to a psychiatrist or to a psychologist according to another statute, and it refers the other statute, okay? And it lists numerous other sort of medical procedures that the physician might do. So you're kind of seeing all kinds of medical care kind of coming together there in a single statute, okay? So I forgot to mention this. So if the physician thinks the patient has some psychiatric disorder or some depression that might be accompanying the request, the physician refers the person to a psychologist or a psychiatrist. And if the psychologist or psychiatrist, or if the physician doesn't think they have a psychiatric issue, the physician is required to send the patient to a second doc who has some expertise in the patient's illness and can affirm that the patient has capacity to make medical decisions, including physician-assisted suicide as an option, okay? So what happens then is that the two docs and possibly a psychiatric or psychological counselor will not only be assessing the patient, right? It's the idea is that the physicians and the psychiatrists are some sort of gatekeeper to physician-assisted suicide. But they're not only doing that, right? They're not just assessing if the patient has capacity to make decisions. They are, in fact, confirming that because the patient has a cancer, the patient's decisions seem to be reasonable. They're kind of reinforcing that, right? You got the power of medicine alongside the power of the law coming together to create a kind of social apparatus that kind of frames everything for you, such that the most rational choice might be that, in fact, I should be dead, right? So the power of medicine and the power of law combine to convince the patient that her choice is reasonable and that it is the right choice, okay? So the medical legal apparatus kind of subtly enforces the right to choose, but also the right choice, I'm afraid of. So when POLST is listed, so one day, the question is this: when will POLST have another checkbox on there that says, I have discussed with the patient the option of physician-assisted suicide or euthanasia, okay? I think we're going to get there. I think right now most docs, even in Oregon and in the states where this is enacted, I think most docs are very reticent to participate in this. I hope that's true. But these things tend to have a cultural life themselves that kind of grows and snowballs, right? Such that this will become the most obvious, reasonable sort of approach, okay? So what's happening, I think, is that our procedures have become unmoored, right? Now, I believe that procedures and policies can be creative in order to encourage habits and the right kind of habits, okay? I believe that's a possibility, right? I believe procedures are created in order to assist in standardized interactions. And I think that's probably a legitimate place for procedures and policies, right? And in addition to that, procedures and policies are there to try to prevent errors from happening to begin with, right? So they have a place, right? But they increasingly become, they're created to secure friendship in the absence of trust, right? There's no trust between the doctor and the patient, such that now we have to have a procedure in place to kind of ensure that certain things do or do not happen, right? And these procedures are created to make up for an absence of character, perhaps. It's usually, oh my God, the doc did what? He failed? Oh, we need a procedure, we need a policy in place so that the doc doesn't do that, right? So procedures and policies are usually there to police, to try to shape it so that when we do fail, and we do fail, I'm not denying that, but when we do fail, that it doesn't happen again, all right? Bad cases make bad law. You've heard that. It was the same way with policies. Bad cases make bad policies. Okay? So what I think is happening is that these procedures seem like they're the right thing to do because they need to standardize and they're doing it for all the right reasons, or maybe not. But they become unmoored from relationships, and at times can be a desperate act to secure a relationship where none exists. And I think that's often the way these things work. And if you're creating procedures to secure friendship in the absence of trust, and if you are creating procedures to act in the absence of character, perhaps we've already lost the game. And I wonder if that's the case. So in other words, procedures have become unmoored from what I would call ontological or anthropological ground, from metaphysical grounding, okay? Essentially, that's the thesis of my book, and I just show how that's happened over the years with medicine, okay? And the question is, what is this ground? And how do we know that ground when we see it? In other words, we've got to go back to thinking about metaphysics and epistemology very carefully, all right? And I would argue that metaphysics and epistemology have to return to theology, the queen of the sciences. And I hope we can argue about this in our small groups. So I'll turn it over to you guys in your small groups, and you can come back and tell me whether I'm right or wrong. Thank you. want to back at 3:05? What time is it?
I think we can be gone until 3:15.
3:15. Okay, we got plenty of time to talk. Awesome. Concise.
Back in this room at 3:15 for open questions.
Sorry, I got lost. Coming back from the back. No, I did.
Take your seats as soon as you can. I know there are lots of questions. Let's get going. You're first. Okay. Yep, if you can come on in. Let's take our seats. Do we have some students with microphones? Where are we ready to go? Where we got? Okay. Ryan's got. Okay, let's begin. Ryan Nash gets the first question.
Jeff, I like your question. I mean, I like the question of mechanized medicine.
1 second. We'll start just a second. Come on in, everybody. All right, good.
I like your question of mechanized medicine. I think we always need that hesitation. One of the, I do work with POLST, and I've tried to further POLST in a responsible way in 2 states. And I think it's generally helpful in creating this B category where it's more than just DNR. But a lot of people that criticize POLST will do this on this nostalgia of the relationship.
Yeah.
I don't know if that relationship, the way that I don't know if it ever existed. I mean, I'm concerned about a society that thinks you need to go to a doctor when you're well. And as a palliative care doc, I also think I have relationship with my patients. I think it's abbreviated. I mean, it is short but intense, and it's intimate, but it's real relationship.
Right.
I just want your reflections on that.
I mean, I think that's right. I mean, you're exactly right. And then the question again is, well, can the procedures that we create enable that? And I think potentially they can. I think procedures can encourage good habits, right? So I think all of that's possible. I don't know that it needs to be a conversation with a particular physician at a particular time. So what I would do, and I said this to my group, what I would do with my patients is I would say, hey, there's this advanced directive form. And I want you to take this home, and at Thanksgiving, around the table, I want you to say, hey, my doc wants me to fill these forms out, and it has to do with death and dying. And it kind of forces a conversation. And everybody's going to remember that, right? Everybody around that table is going to remember. They're going to probably remember what Grandma has to say, right? They'll start a fight, I'm sure, but these are messy conversations. So what I want to see is something cultural where families have those conversations, and the day of Marcus Welby, MD, right, who is kind of considered to be an honorary family member, are gone. I think that's right. So I think there ought to be cultural practices around this that are very different from what happens with the doctor. Then I want her to come back, and I actually don't care whether or not she's filled that form out. I just kind of want to know who I need to talk to when something bad goes wrong. Because I'd rather reason with somebody in the moment about what's going on than to look at a piece of paper, even a POLST, and try to figure out what I'm supposed to do. So having somebody there to reason with, and if everybody was around the Thanksgiving table has had that conversation, right? Everybody heard it. The kids will remember it. I remember do you remember when Grandma did that? Oh, wow. Is it time for us to have that conversation again? And so, I mean, it becomes something that everybody witnessed, everybody heard. It becomes, I think it becomes kind of natural. I think it's culture. If we could enculturate some of these practices, that would be better. Now, we live in a fragmented culture. So I am not in any way suggest. I'm not a romantic about any of this, really. We live in a fragmented culture, so I agree with you that we ought not romanticize the doctor-patient relationship. I think the CMA, in their critique of POLST, has romanticized that relationship, and I think that's problematic. I think that's problematic. Yeah. Oh, Easter would be better. Yeah. Easter would be better. Absolutely.
Thanks for a great talk. I think I was going to ask just along the lines of how you responded at the end of your response. I was going to ask you, whether you think that forms, whatever the forms may be, have become a substitute for practical reasoning amongst each other and practical judgment, and whether the best thing wouldn't be to throw out forms altogether, because ultimately, in the end, there's nothing that's a substitute for talking to someone who cares for that person, period, end of story, because situations are changing all the time. And the second follow-up was, given a pluralistic culture, how viable would that sort of proposal be? But I know I would not ever sign a form like this, period. So anyway.
Yeah, I mean, I think, again, forms are, as I said, they can become substitutes. They ought to frame for us maybe conversations, and I think some people need a starting point, and forms give you a starting point. But like I said, I don't care about that form. I care about the conversation they had, and with the people I'm going to be conversing with to help sort through these finer, nuanced judgments that have to happen at the bedside of someone who's critically ill. I want those informed by people who've had nuanced discussions with grandma about, the meaning and purpose of her life and what she would and would not want. So I think forms and procedures and policies can enable good habits. The problem is they become substitutes for habits, and that's where the problem is. And you're right. I don't know what we do. We're in a fragmented, pluralistic culture, and we don't necessarily. I mean that. I don't have any answers. When I see priests in the room, I say, it's your job to help figure this out, right? Help us sort through this culture. And so I'm not trying to abdicate responsibility. I'm glad it's your role. So,
is there any data about physicians' response to POLST? Are physicians generally in favor, supportive, or not? To be honest, I mean, they make me very nervous, just because I always think of my orders as embedded within a particular context. And the nice thing about a hospitalization is when a hospitalization ends, we reestablish and we reevaluate. And so, to me, taking a set of significant orders like these off 12 months into the future, I mean, that makes me nervous.
Well, this is one of the critiques, is that most of our decisions, as you pointed out, are context dependent. What are the vicissitudes and the nuances of what's going on in this particular patient, in this particular bed, at this particular time, in this particular space, right? And so you change your judgments all the time like that, and POLST does. And that's one of the biggest critiques that the CMA people, as well as others, have made of the POLST paradigm. Now, Donna in our group made a really good point. She said, well, I want people to have those conversations when it's not high pressured and all of that. So we want to have our cake and eat it too. And so I actually think Donna's right. But again, I don't think it necessarily needs to be me signing an order. I'd rather this be a conversation that everybody kind of has a memory of what happened, and they can check each other's memories when they gather around the bed. Now, the problem is there's probably usually one child who shows up and it's their interpretation. I know this is a problem. I'm not trying to be Pollyannish here, but I see them as these documents that could enable good habits. But I don't think they do that in our context. And part of the reason they don't is precisely because we don't have a context, a cultural context within which those practices can flourish and grow up. So,
Jeff, I want to try to articulate a kind of nagging worry that I've had for a couple days now, not just from your talk, and see if you can make sense of it for me. For instance, to go back to Loris's talk, if we're going to establish goals of care first and then we're going to decide what treatment follows from that, or in a family-oriented way, as you described it, where we're going to sit around the table at whenever, Thanksgiving or Easter or whenever, and hear what Grandma has to say, so that we have a better idea what she'd want at some point, and so forth. What if Grandma's goals turn out to be all messed up? What if what she wants, and we're all agreed, we heard her say, don't seem to be the best care? I don't know kind of where this whole way of thinking leads under those circumstances, and I wonder if you would comment on it.
Bill, you are wiser than me, so I was hoping you could tell me what the answers would be on that. So, I mean,
What do you mean by messed up?
so if Grandma decides, keep me alive forever and ever, even though there's no hope of getting out of the hospital, that could actually be highly problematic, or it could be the opposite.
Well, at least until the head transplant actually is done.
Yeah, until the head transplant's come in.
Or alternatively, do everything you can to see to it that I leave this vale of tears soon. Yeah,
Go quickly, go easy, and give me that bolus of potassium chloride.
as much as you can. Yeah.
Right. No, I mean, you're absolutely right. I think we're in that situation right now. So I think pointing it out right now that this is the situation we're in, I don't know if we have, I don't know the way through it, but I think that's just where we are, right? And again, this goes back to formation. It goes back to what goes on in parishes. Yes, people may not be Christian, etc. I know all of that, but at the same time, those who are fully secular still have ontological commitments. They still have faith commitments about what the reality of being human means. And so I think they too can have those conversations about that. Now, I know we're in a fragmented society, and I'm going to be stuck either choosing to do something a patient wants me to do that I cannot morally do. All of that's still possible. Absolutely.
Yeah, we got a long. Let's try to get Kevin, Sean, and Chrissy, and then Dr. Shore.
Let me have that.
Right. And our Canadian friend too. Jeff, one short point and then a follow-up really on Gil's. The short point was for POLST. One of the things that bothers me about it, and I hope other people feel the same way, is the fact that there are very few forms that we see that are physician orders, signed by practitioners that have no privileges in the institution in which we're working. And in states that have enacted POLST without a registry, we don't know who the hell signed that form most of the time. Now, thank God all physicians sign legibly, so at least we can figure that out. But the other point is a little bit more general, and POLST is, I think, a strong example of the general point. I think one of the reasons we're getting into trouble is because, as physicians, we are not honoring our own commitments to offering the best treatment to our patients, but asking them how they define the best treatments. It is a value judgment in many cases, but before it becomes a value judgment of what the patient values, it is a medical judgment about what is valuable or effective as well. And if you look at the back of the POLST form, it isn't just a DNR. The one in Maryland, the closest state that has an active one to me, we see patients who have checked off, I want antibiotics that are IV or oral. I want to be intubated with a 4.5 tube, not a 4.0.
Yeah.
Okay, I lied about the last part.
Yeah, I know. But it does get ridiculous. So you're making a good point.
And I think even when it comes to a DNR, we know when that's likely to be helpful to a patient. Why are we burdening families with whether or not somebody should go through useless CPR just before they die, when we really know in most cases when it's not going to be useful? Why don't we tell them that?
I mean, you're absolutely right. We've abdicated certain responsibilities, and this goes to the question I asked, Loris in his talk. What's the relationship between goals of care and goods? And I think that we have to start talking about what is good for grandma, not what is the goal. So I think you're exactly right. And we do know. I mean, there are times when I know, statistically speaking, in my best judgment, and people don't like the fact that I might say this, but no matter what I do, this person is going to die. And then we don't take the bull by the horns and say, and therefore there's no medical option here. And it's not really a choice for you. It's really me deciding, and this is going to maybe make some people angry, but me as the physician deciding that I can't keep the blood going round and round to any good that you might have. And I think that then becomes problematic, I know, for some people. But I think there's a certain amount of that where we have to understand that our decisions are value-laden, not just goals. And that's why I was asking, for Loris to tell us what the goods were. Not that he can't. I know he can. And that's why I was asking Loris that question, right? Because I know he can tell us what those goods are. So I wasn't trying to be mean to Loris. Where are you, Loris? Speak. So let's go to another. But you're exactly right.
Great talk, Jeff. And I think you're getting us to think about checkbox medicine, which is driving me wild. It doesn't replace the integrative thinking and the way we've been trained, all the training and education experience we've had as physicians and as healthcare practitioners. But having said that, when grandma gets sick at home and collapses and gets driven to the emergency room, you're not likely to be there. And even though you've had that previous conversation with her, I think that your comment about Thanksgiving dinner discussion is probably more important than discussion with you. Because at least, probably, it's more likely a family member is going to at least be called, contacted, maybe accompanying the patient. If she doesn't have decisional capacity, somebody has to know her values and preferences. Otherwise, the emergency medicine doctors who are seeing this patient for the first time in extremis are going to default to resuscitation, and way more resuscitation is going on in this country than what people actually want. So I think POLST is helpful, at least to have documented a conversation. And you can't replace a thorough conversation about someone's preferences and values for life with a document and checkboxes, but at least it can be a substitute if you don't know otherwise.
And I completely agree. And so I think that's exactly right. So I get a form. If I was in the emergency department as a resident, I'd get a form. I'd be like, I have no idea what this means, because this patient might have a terminal condition, but it's also, this acute thing is reversible, and it might be easily reversed. And then I'm forced to kind of go, decide whether to go that way and perform CPR or to intubate the patient. And there are probably times when I should intubate the patient with a reversible condition, even in the context of a terminal cancer, that this is just an acute little problem that we can take care of with a day or two on the vent. So I wonder if we have to start getting back to some value-laden decisions that we have to make. But you're exactly right about the conversation. I agree. I don't think they have to have that conversation with me, but I do think if they have it with their loved ones, somebody's going to show up at that emergency department eventually, and any doctor can then reason with that person about what the clinical decisions ought to be.
Because the reality Ryan pointed out is that, at least in the VA where I work, the primary care doctors don't take calls, so they're disconnected. Patients in our system frequently see the emergency department or hospitalists are admitted to the hospital way more often than they do the primary care doctors. The family members are really important.
From the psychiatrist's concern, I was sitting here thinking, of course, I'm a layperson, I don't have any medical training, but I was sitting here thinking, this makes me a little nervous, just this open-ended document that just sort of doesn't have a fuse on it based on changing circumstances or something else that might occur. I have no idea whether that's a real concern or I'm just making that up, but it would be workable or practical, or would it be something to consider to have a fuse on this that just sort of expires at some point in time and requires a reevaluation?
Of course, but this is the thing. That was supposed to be what we do as docs anyway, right? We're supposed to say, oh, well, these orders no longer apply, and therefore they're going home. We have to write discharge orders that are directed towards some things that are achievable as an outpatient, or these orders are written for the nursing home or the other skilled nursing facility. Every time. So that's what the old orders were. When we discharge a patient, we rescind the hospital orders and we give new orders that are supposed to be for a different context. So we did have a fuse. It was discharge to home. Do this, do that. So I wonder if we're yeah, Anik wants to say something. Go ahead. I know. I, I, I agree that there are procedures and policies that are in place that are at least the good ones. We'll put procedures and policies in place. So I don't want to be saying, like I said, these things are just things that might enable good habits. Okay. The problem I have is we live in a context in which we follow those things without inculcating the good habits. So look, I agree. POLST can be a good thing. POLST can be a very dangerous thing. And I worry that when it becomes that tick box, have you had the conversation about physician-assisted suicide in those states where it will be legalized or is legalized, that it becomes a different kind of thing yet again, right? Margaret is in charge.